James, you want to do a little intro?
Yep, cool. We're back. Lockdown series episode. We shouldn't do
5.
episodes because we forget the fucking numbers. 5, yeah, can count to 5. And we've got a special guest, Stephanie Hill. Dr. Stephanie Hill, I should say, really.
I don't mind. I've said before, I get twitchy when people call me doctor. I don't tend to respond when I'm at work, and if one of the nurses calls me doctor, I don't even look up. They have to call me Steph, otherwise I don't realise.
So, Dr. Steph, how long have you been a doctor for? Can you give us a little bit of background about yourself?
Yeah, sure. So this is technically my 4th year qualified as a doctor. So I did 7 years at university because I went the long way around. I did a 3-year biochemistry degree first, then I did graduate entry medicine. And so I qualified 2016, and then I don't know how much people will know about the training when you're a doctor, but basically you go into your 2 foundation years, foundation year 1 and 2, F1 and F2. Those 2 years are made up of 3 4-month placements, and you rotate around all different specialties in those 2 years. So you have no choice really as to what you do. You have to cover medicine, surgery, GP, all sorts. And then after that, you get to then sort of hone your specialty and decide a bit more. So once I did that, I decided that I wanted to do end-of-life care. So I chose a training pathway it's not classic for end-of-life care. Normally you go into medical training to do that, as in you work on the medical wards and then you become a end-of-life care doctor, a palliative doctor. But I decided that I wanted to do palliative medicine within acute settings, so within intensive care, within A&E and the acute medical unit. So I chose to do a training pathway called Acute Care Common STEM. And so my last 2 years have involved 6 months of the acute medical unit, 6 months of A&E, and then 6 months of ITU. And as of a couple of weeks ago, February, I just moved into my anaesthetic placement, so in theatres, but now I've been moved back to the intensive care unit because of everything that's going on.
Okay. So did you always want to be a doctor?
Yeah, always. Since I was really little. There's a picture of me in my year 6 assembly where we had to dress up as what we wanted to be, and I was dressed up as a doctor. There was a transient time where I wanted to be a vet instead of a doctor, and then I had a gerbil, and my gerbil bit me, and then I decided, nah, screw that, I'll go back to being a doctor.
Oh, that's funny. So ICU, was that always a conscious decision from the get-go, or did you
It was in terms of my because so end of life care is my end goal, but I do want to do intensive care in terms of palliative medicine on intensive care. And I had a placement in my foundation year 1 year, which was ITU and anaesthetics, and I absolutely loved it. It's like the way I saw it was, it's really intense medicine. So I don't know if you've ever watched House, the TV program, but it's like he's an American diagnostician, so he just gets these really complex cases and has to try and work out what's wrong with them. And as a really junior doctor, that's how I saw ITU, because these patients are really sick. Sometimes you know what's wrong and sometimes you don't. But it just means that you have to think really hard. You have to really use your brain, think about how the body works and why their body's gone wrong. So that's why it's so interesting. And people get really sick for lots of reasons. So in intensive care, you see surgical patients, you see medical patients, which is a bit different to everywhere else because you tend to specialise otherwise. But then palliative medicine, so end-of-life care and ICU is obviously very important as well, because unfortunately 15 to 20% of people on ICU won't survive, and that's before COVID came along.
So it must be tough to deal with as a just getting qualified, then being around that sort of percentage? Like,
Yeah.
how did you? Is there measures in place to help you guys deal with that sort of environment, or that sort of like constant loss of life?
Not no, not officially. I think the doctors that you work with and nurses that you work with are aware that they need to support you, and you're always very well supported, especially in specialties where death is paramount. Sort of so palliative medicine, palliative doctors will talk a lot about self-compassion. And I went to a palliative conference last year, and the whole day was actually about self-compassion, was about how the doctors and nurses look after themselves as opposed to how they look after the patient, because they recognise that there is such thing as compassion fatigue, and if you let that build up, then you won't be able to perform at work. So it's down to you really to speak up about it. You could very easily suffer in silence, I'm sure, but you've got to make sure that you've got a support network around you. But no, there's no official person coming up to you asking if you're okay.
So with that, so you mentioned obviously COVID there. How has this pandemic changed your time at work? Like how has this really changed things up in the hospital to give listeners an idea how you're currently working to before?
So it's changed everything. It's changed absolutely everything. It has changed who works where. So I said I just moved on to anaesthetic, so I've been moved back to intensive care. But that it's not just me that's been moved. There's been lots of doctors that have been moved. So when I talked about the foundation placements that were 4 months long, they're meant to rotate in April. So basically the Medical Health Education England, who govern all of the trainees, have said that nobody is to rotate in April. They have to stay where they are. That's huge. That has massive implications on training. So they're going to effectively miss out on a whole 4 months job, and they're going to do an extra 4 months in a different job. They have had to move anaesthetic consultants, so the consultants that put you off to sleep for an operation, mobilise them into coming to help intensive care, because all elective surgery has been cancelled, as I'm sure you would have seen. So the amount of operations that need doing are far, far less, which means that their resources and their time can be used elsewhere. All other doctors that are above Foundation 1 and 2 have been sent back to their base specialty. So if they're doing medicine, they have to go back there. If they're doing surgery, they have to go back there. So it's a big uprooting for lots of people. I'm absolutely thrilled to be in intensive care, and I wouldn't want to be anywhere else during this pandemic. But there are people who have been moved there who don't like it, and we're very glad to have moved on from it. And other things, so they've cancelled all exams. So once you get past medical school, it doesn't stop there. You have to sit lots and lots of exams to progress through your medical career, but they've cancelled all of those. So basically none of us can progress through our training, and we're all working in a different environment to we were before. So that's the working and training side of it, but then the physical side of it is very different as well. So the setup of the hospital is different. We have wards that are COVID wards, so they are what they say on the tin. Anybody who comes in through A&E who is suspected to have COVID will go to one of those wards until we wait for their swab to come back, and that's obviously to contain the infection. Our intensive care unit has had to expand, so we have 2 intensive care units at both hospital sites, and then we've added an extra one at each site. So yesterday we spent time moving down the patients from one intensive care unit to the new one downstairs. And basically now the ICU downstairs is going to be the clean unit, so nobody on there will have COVID. And then the 2 upstairs are for the COVID patients. So loads and loads of changes. And I could go on. There's even more, but I don't want to bore you.
No, people want to know, like, genuinely, like, we sit and watch the news or catch up on whatever. And, you know, we were doing a podcast yesterday at 8 o'clock. Everyone's back outside clapping for you guys, which obviously
Yeah.
is doing a great job. But everyone, well, for me, even personally, I want to know what it's like for you guys, like boots on the ground. Like, what is it like for workers?
Okay.
Like, it seems like you guys would always plug together anyway. I think it's kind of, I would just assume that you guys kind of know what you sign up for.
Yeah.
Like,
Yeah.
Public service says it in the name. This is now
Yeah.
like, it's kind of like your time. Like, you're helping the whole country now. Like, you guys, people that are working in shops, you know, like delivery drivers, these sort of people, they're like the nuts and bolts of the whole country now.
Yeah,
So
absolutely. I'm really glad you said that as well, because actually that's how we see it. And a lot of us are actually sat at work being like, so lovely having all this support and having all these people give us free stuff and clap for us, but ultimately we're doing our jobs and it is what we signed up for. As I said, I wouldn't be anywhere else. If you told me I could stay at home and I don't know, I'd get paid just to stay at home and do yoga or whatever, I'd tell you where to go. Like, I want to be there. I want to be using the skills that I've been trained to use and helping people. And all of my colleagues feel the same. We're all petrified, as I'm sure you can imagine, and we've had to learn a lot of new things. For example, when somebody comes to intensive care with COVID, the reason that they're coming to us is because they're not getting enough oxygen, and in order for them to get enough oxygen, we need to intubate them. And intubation means that we put them off to sleep, so we induce a coma, and we put a tube into the mouth, down through the vocal cords, into the lungs, and we plug that into a ventilator that then allows us to give them the oxygen that they need, and it helps us to push it in with enough pressure, basically, so that their lungs can expand. By putting the tube down into the lungs, we are putting ourselves at huge risk of getting infected. It's what they're calling an aerosol generating procedure. So a cough is an aerosol generating procedure. But in terms of medicine, intubating and taking the tube out, so extubating, are all aerosol generating procedures. And so we have to wear like upgraded PPE, if you like, personal protective equipment, and we have to do specific things differently compared to how we would intubate somebody on a normal day. So learning that, when you, especially some of these consultants who have been intubating people for years and years and years, their own way, the same way, the fact that they have to come back and learn how to do it differently, that just must be petrifying for them. I mean, it's petrifying for us as juniors, because I won't actually be putting the tube in. I may do it at some point, but if it gets to that, then we're in a bad state of affairs. I should be helping by giving the drugs, plugging the ventilator in, that sort of stuff. But even for me, the concentration that it takes to take all that information in is just massive. And the pressure of making sure you've put your personal protective equipment on right. There's like a whole way to put it on, and there's an even more specific way how to take it off. And all this stuff we've just had to learn so quickly. And I mean, I had to do it for real, not last weekend, the weekend before. And it was nothing like we'd practiced, because things never are they? When it came to the real situation, we were just like, what do we do again? And nothing went as it should have done. We didn't have what we needed there, and it took longer than it should have done. We learned a lot of lessons from it. I went to handover in the morning because it was a night shift, with a big long list of things that basically went wrong, and that we need work on. And by the end of the day, I'd got a text from the consultant saying, here's your list. Here's a list of the answers to your questions, and this is how we sorted it. So we're all just learning as we go along. No one's an expert in this. Nobody has seen it before, even the consultants. So they've seen the acute respiratory distress syndrome, which is basically the inflammatory response of the lungs to an infection. They've seen that before, but nobody has seen it from COVID before. So everybody is just learning. And we're learning from the different countries as well. There are numerous webinars each week where consultants from Italy, from America, from China are talking to us about what they're doing, what's worked, what hasn't worked, and just desperately trying to learn from each other so that we can take it forward. I mean, last week they told us not to use a specific type of ventilation, and then this week we are to use it. So it's changing that rapidly, and they're big changes as well.
And you see, with these changes as well, do you necessarily get an explanation for those, or is it that's the best way to do it and it's sort of implemented on that?
Yes, and none of it is really evidence-based, in that we haven't had time to do trials and document numbers and have a look if the cost outweighs the benefit. It's just, we tried this, anecdotally we think it worked, so probably you do it too. Which is not how we're used to working, especially on intensive care as well. We like our protocols, we like our evidence, our research.
Yeah, it must be. What is the general morale of staff within the hospitals like? What is the general? Can you give us an idea?
Yeah, so I think it's quite good, actually. I think it's good. I think we've all got a sense of togetherness, and we're all sort of riled up, ready to go. So we haven't been hit hard yet. But we know it's coming, and we've done all this training, and we're starting to see it. We're starting to see an increase in the patients. So there's the fear there, but I think a lot of us, especially working on ICU, we've got a stiff upper lip. Like, we do just get on with things, and we're quite good at just putting things aside. And so it's good, but I just worry that underneath the surface, whether it is or not. And I'm trying to do that at work. I'm trying to, because I personally spend a lot of time looking after myself. I journal every day. I try and be as mindful as I can, and that's taken years to do that, because I'm aware of that sort of thing. And I know that I need to take time to myself. I can recognize when I'm getting stressed. I know I need to talk about things. There are other people who just will not do that, majority of people. And so I do worry about them. So I'm sort of forcing them to talk about it at work, especially with the nurses. The big thing that's upsetting them is that we can't speak to families. So obviously, normally, if we've got someone who's really sick on intensive care, then their families are in with them, and we're able to talk to them every day, whenever they want to, for them to get updates and for them to tell us what we can be doing that their family member likes. But there's just none of that, and that is a huge, big part of the nurse's job as they see it. And one of them said to me the other day that when it gets to the point where we can't do anything else for a patient, I shouldn't word it like that, that's not the right way to say it, but when medically we can't treat their disease anymore, and what we can do for the patient is make them comfortable, often the nurses will get solace from the fact that they can say, we'll make them comfortable, you can be with them, and they work with the families to do that. That is like 50% of the care that they do, and that's just been taken away from them. So they're finding that really difficult. I don't think anybody really started talking about that until I probed them, sort of said, we really do need to start talking about what's bothering us. And then I had a good chat with quite a few of them yesterday about that. So I think they are starting to become a bit more self-aware.
That's the other side of it that no one's really talking about, is the mental, like you said, a mental strain of such pressure. Like you were saying, like things are changing on a daily basis. Change is stressful for a lot of people, to be honest. Even like tiny stresses, like, oh, someone didn't use a cup that I use every day. That can stress people out. So that's something so tiny. Then you guys are in such a, well, it's a historic moment in the world, basically, and things are changing on a daily basis. That stress must just be, well, for me, it's kind of unimaginable. So it's obviously, it must be a concern to people that, you know, what is people's like mental well-being going to be like after this hopefully has passed.
Yeah, well, they did some research into this, looking at the SARS outbreak, and they found that when they interviewed healthcare professionals, there was about a 10% rate of PTSD. That's compared to 3 to 4% in the general population. So it's a significant increase. So I do worry about that, and I think there's going to be, that's going to come from different aspects. So for us in intensive care, we're used to people being very sick. We're used to seeing all of the tubes and lines and everything that they have. That is our everyday, and we're used to people dying. And as wrong as that may be, we know how to cope with that, which is a whole different topic, isn't it? That we can be so okay with that, but we can, and that's that. What will be difficult for us on intensive care, and hopefully it won't get to my level, I'm not sure, it may do, it probably will do, it will be the decisions we have to make, will be the resource decisions when things are very tight, and we have to make informed decisions as best we can as to who we can admit to ICU and who can get what treatment. And on a normal day, that will be at least 2 consultants having a discussion. They'll be able to think it through. But we know that we're going to get to the point, because we've seen it in the other countries, where those decisions are not going to sit well with us. We're going to have to make decisions that on any other day we would never make. So that's where our PTSD is going to come from, I think, when we think back about how much of a huge, we're basically going to play God, and that's not going to be okay with anybody. And I don't know how we can even comprehend that to cope with it. And then we also have to deal with doing a bad job, basically. So on ICU, everything is one-to-one nursing. There are lots of doctors about. Those patients on ICU get perfect care, tip-top, everything. And we're just not going to have the time or the resources to work that well. We will, of course, be doing our very, very best and giving everybody the best we possibly can. We're still not going to measure up to what they would get on a normal day. And the type of person who goes to work on ICU, both nurses and doctors, are the type of people who need that perfection. There are jokes around comparing ICU nurses to A&E nurses, because A&E nurses are very good at just mucking in, getting on with it, regardless of if their patient's a mess. They can dab in with one patient, then go off to another one. Whereas ICU nurses, everything has to be pristine, neat. If you go in and mess up their patient's bed sheets, then they're going to hate you for a long time. So that will be difficult. But then on the flip side, there's these medical wards that have been set up for the COVID patients, and the staff on those medical wards are not used to people being very sick, and they're not used to all the tubes and lines, and they're not used to people dying. And how it stands, if someone gets very poorly and they need intubating, we have to do it on those wards. We don't bring them up to the intensive care unit and do it as we would normally. We have to do it down there. So that staff on those wards are going to be seeing things that they've never seen before. They perhaps don't understand, because they wouldn't ever have had to. And it's going to be absolutely petrifying. And the boss of the hospital, I should know his official term, but I don't know his official term, very kindly came to visit all of the specialties on, not yesterday, the day before, I've lost track of days, and he sat down and he asked us if we think he could be doing anything else. And so I said, I think that's what we need to be doing. I think we need to be going into those wards and sitting down with that staff base, explaining what intubation is, explaining why we do it, explaining what it's going to look like, and just telling them that it's okay to not know what you're doing, and it's okay to feel shit about it, because you've never seen that before. I mean, it's not nice to see somebody be intubated. We know that they're asleep with the drugs that we're using and it's a controlled environment, but they don't, because they've not seen that before. So I think that's where their mental health might suffer. So there are lots of different aspects. I'm not sure all of it is being thought about either.
And I wanted to ask as well, so do you know, we've been on the front line, and I'm anyway seen loads of news reports of different age demographics being affected by this. Like, have you been able to, or can you like tell us at all who you've seen or what age demographic seems to be affected by this at the moment that you've seen of it?
Yeah, so we haven't got a huge patient number of COVID patients in my hospital, luckily, because we haven't been hit yet. But they tend to be sort of middle-aged people, actually, that we've seen. I'm obviously not allowed to talk about patient specifics, but I think generally what they're seeing is middle-aged men. Statistically, they're seeing men more than women. The thought behind that is that is to do with your immune system. So women as a whole get more autoimmune medical problems because our immune systems are just a little bit more ready to go, if you like, and the result of that is that they sometimes attack themselves and give you autoimmune diseases, but equally it means that they're more ready to fight off foreign things as well. None of this is medically proven, apart from the women getting autoimmune diseases, in terms of COVID, because we just haven't had the time to prove it. There's also some discussion about whether there's a medicine called ACE inhibitors, which is a medicine that's given for high blood pressure, whether that is increasing people's risk. Again, we don't know. I think that was probably hypothesized because the way that the virus gets into cells is via a receptor that's the ACE2 receptor. So people probably got their knickers in a twist and thought that if they're on ACE inhibitors, then that's going to make them more likely to get it. But there's no evidence for that yet. I think probably more likely if you are someone who is in that patient group that is having to take ACE inhibitors for your blood pressure, then you're more likely to have medical problems that mean you would suffer more from it. Does that make sense?
Yeah.
So when, sorry, carry on.
As I say, but other than that, the one thing that we do know is that the severity of your disease and your chance of not surviving the disease goes up with age. And although there have been cases of younger people, the 13-year-old who passed away a few days ago, which is really, really sad, those cases will happen, but thankfully there are much, much fewer. And children don't really seem to be affected that much.
So there's still a lot of talk of like people like our lockdown is not harsh enough. Like I've got colleagues in Germany and France, and Julian has friends in Paris and around the world. And the common thing is like our lockdown is nice in a way, right? Like we still get to go out, still fairly trusting. We still, go to the shop, exercise, but do you think it's personal? Like it's more of a, like your point of view. Do you think it's harsh enough? Do you think it's strong enough to contain what we're seeing, or should it be firmer?
I think it's a balance, isn't it, between doing what we need to flatten the curve, but also maintaining people's mental health, because I think the UK as a whole has an issue with mental health, doesn't it? And we do need to be very mindful of that. And I think that is what they're doing. If mental health went out the window and everybody could cope well with staying at home, it would be 100% better for everyone just to stay in the houses and not go out at all for these exercise walks and stuff. But it just wouldn't work, and only time is going to tell as to whether we have flattened the curve or not. What worries me most is that people are not abiding to the guidelines. I think now the majority of people are, but there are still people that aren't. And I think it's through lack of understanding. So when I hear people say things that they've done, so one of my mum's friends, I'm sure my mum won't mind me saying, or her friend won't mind me saying, but she went out for a walk with her elderly neighbour, and they've been friends for ages and ages, and I'm sure that she's thinking that she's helping the elderly neighbour by being friendly, but actually that's not allowed. You can't do that. You can't go for a walk with somebody who's not in your household. But I don't think she would have known that. I don't think anybody would have clearly said it to her. And also I worry that now, so we've been on lockdown since, when was it? It's been over a week now, hasn't it? And was it the 19th of March? I can't remember. Anyway,
yeah, not
I
last
think
before.
Yeah, so long enough for people to get bored of doing it, and long enough for people to sit there and think, well, this isn't that bad, is it? So maybe I can go out for 2 walks, or maybe I can pop round to Julie's house for a glass of wine, or people are going to start bending the rules because they're not seeing a consequence, because we're not there yet. And that's what I really wish people would understand, is that the work we're doing now is 3, 4, 5 weeks down the line. So we haven't seen the effects of all that time people spent together before the lockdown yet. That is to come.
Is there an expectation internally of timelines, expected timelines? I know I get it. It's impossible to say no. And if someone had that answer, they'd be the most famous person on the planet.
Yeah.
Is there kind of you guys should be braced for?
Yeah. So
120 days of this kind of work.
I think the fact that we moved to our new ICU yesterday says a lot. So I know that over the last 24 hours, 36 hours or so, we've seen almost a doubling in the amount of patients that we've had to take to ICU. We haven't got a huge amount of patients there, but that's still a rapid increase. So we can sort of sense that it's starting to happen. I think over the next 2 weeks probably now is going to be when we see it coming. That's best guess though. The consultants are clearly worried about it, because that's why they've taken the move to move the patients downstairs now preemptively, because they didn't want it to happen in the middle of the night, basically. So they're expecting us to spill over onto our second ICU pretty soon. So yeah, my best guess would be over the next 2 weeks.
Yeah. And then, do you know what? We might as well warn you, this is probably going to drop off in like a minute, because we're cheapskates and we won't pay for the premium version.
Okay.
So if it cuts, we'll just call you back.
Okay, cool.
We're not just ending it, don't worry. We've forgotten still.
Gosh, you talked so much, I don't want to hear her anymore.
No. So it's shall we just do that now?
Let's
Yeah.
quickly cut and
all right, we'll send you the new. You want chatty guests, or me and Julian just do our own show?
Oh yeah, well that wouldn't be too bad, would it? But no, you're right. The whole point is to chat.
Exactly. You're the first person we've never met before to have on this. It's like the first time meeting you.
Yeah, I was thinking that. It's weird, isn't it? But yeah, I'm like an overly sociable person, really. So I'll just, I'm easy.
That's perfect. All right, are we recording again?
Yeah, we're back. We're back in.
All right, sick. What was the next question we said?
So you wanted to know, so when things would start to tail off. Well, I get an idea of when isolation, so to say, might be put to a stop for home
Oh yeah,
residents
so
in the UK.
they've thrown out 6 months for isolation. I'm not sure where I've heard that from, but that's what they're talking about at work. And basically, if we do a really good job of flattening the curve, then it could last that long. To be honest, personally, I've kind of written off the rest of this year in terms of any events that are going to have vast amount of people. I compete in bodybuilding shows as well, so that's another thing. People are trying to decide whether they're going to have their shows or not, but I really just cannot see it happening. Yeah, so a long while yet still, I think.
Yeah, I think that's you see it. We were talking about it on the podcast yesterday, and James, who was on, was saying that he sees stuff online saying, "Can't wait to be back out in a week, in 10 days, back in a have a drink with my friends." And we were all saying like it's quite a bit scary that people actually believe that all the like town's going to be open. You can just go for a bit with your friends. Everywhere's going to be open. All the gyms will be back open. It's just not. It's not going to happen, is it?
No, it's not going to happen. And I think maybe when they first said about the lockdown, sure they mentioned 3 weeks, didn't they?
Yeah.
I don't really know why they did that, but it's definitely going to be longer than that. Maybe that's where people are getting their week 10 days from now. But I almost think there's no point in hypothesizing how long it will be. I think it's probably better to spend your energy focusing on how you're going to do the time sort of thing. And then, because if you're spending time thinking about when it finishes, you're not in the moment, are you? You're not working on how you're coping with it now. So just imagine it's going to be for the rest of this year. Start to get things in place so that you could cope with that, and then you win, don't you, if it's shorter than that?
Yeah, you're right. I just people will not want to have that conversation with themselves.
No, and especially the people who are, I mean, as well, it might not sound strange, but we have all said at work as well how lucky we are actually in this situation, because although my shifts have changed, my routine as a whole hasn't changed that much. I still go out to work. I still get to socialize at work, in terms of still get to speak to other people that are not my partner. I feel so sorry for him. I'm coming home and I'm the only person that he gets to see, the poor lad. But so we get to go and see lots of different people, and we get to do our job, feel like we've got a purpose, we get paid, we've got job security, we've got none of that to worry about at all. So when we're getting all this praise about being on the front line, it almost makes us, I've heard lots of people say it as well, it makes us feel uncomfortable, in that actually we are really well off in this situation. Yes, we're fighting COVID or whatever while we're at work, but that's just glorified what we normally do. And then also all the other boxes we've got ticked and that other people do not have ticked. So I can appreciate that. I could do this until the end of the year, but people who have lost their jobs, who have no income, who are relying on their savings, can't. And that's what's difficult, isn't it? And I think that's probably those are probably the people who are focusing on the fact that they want to be out in 2 weeks, because that's what they want to happen, and there's good reason for that.
I've got a question. Did you feel undervalued before this? Did you feel like a bit invisible in terms of like now? It's like, it's kind of annoyingly, it's kind of like, oh, some people will just clap you and put it all over their Instagram because everyone's doing it. So it's like cool to do it now. It's nice to do it now. It is nice. But then before, was it kind of like, oh, none of you just took us for granted before now?
I think I've never felt taken for granted. I've said previously that normally not a day goes by without somebody saying thank you to me. So whether it be a patient, whether it be a nurse, whether it be one of my consultants, somebody usually does say thank you to me at least every other day, and I make sure that I listen to that and take it in. And also, when my job to me is not altruistic, I get a lot out of doing my job. I enjoy it, and I enjoy the fact that I'm helping people. What is it? It's hard to explain. I basically, before this, I went to work. I worked on ICU. I saw people really sick. I saw people pass away, and that was my life. I dealt with it. I did it. I talked to my mum. I talked to my partner, and we all knew what it was about. We got through it, and that's fine. But nobody on the street would be like, "Oh, thank you for doing that." Or I've got some of my friends from school that I haven't spoken to in years messaging me, being like, "Thinking about you." There are some days that I really could have done with that. But that never would have crossed my mind. So I never would have thought that's what I need. And I never felt like I wasn't getting it when I should be getting it. It's more like now it's just weird that we are getting all of this support because we're not used to it. And from the general public, it's lovely, and it does make us feel a bit uncomfortable just because we're not used to it. That's not why we do our jobs at all. I think that's why right at the start when I said, when you called me doctor, I don't respond to doctor, and that it's bad, isn't it? But I've been told off for it so many times, but it almost makes me cringe when someone calls me doctor, because when it's like when someone asks me what I do for a job, and I think when you had I've forgotten her name, the dentist who you had on.
Bethany.
Yeah, I think she said the same actually. When someone asks what you do for a job and then you say I'm a doctor, it just kills the conversation completely. And there's almost that automatic, oh god, that's really good, like I can't say anything now. And that, I hate that. It makes me cringe so much. And that's what we're getting now on a daily basis, basically. And yeah, it's really lovely, but it's not going to last. And the thing that gets me is how the government is acting towards us. Like they've just wiped all of the NHS's debt.
It's like 140 billion.
Yeah.
Just like, gone. Like,
yeah.
Amazing.
But why didn't they do that before? I mean, my mum was like, my mum told me when she was on the phone, and she said, why didn't they do it for their 70th birthday? I was like, yes, that would have been lovely.
Right.
But it's just things like that it makes you think, like, why were we treated so shit in that respect before? I've never felt undervalued as a person or as a doctor, but I've felt like the NHS as a whole is not getting the support that it should have.
Do you think that had a knock-on effect to how you can respond to the current situation? Do you think there's obviously like some sort of domino effect of neglect or underspending or cuts that's now having a knock-on effect today?
No, I don't think it is, because they've literally just pulled out all the stops and they've said, just do what you want and we'll pay for it, basically. So all the wrongs can sort of be rectified very quickly. If we haven't got enough doctors, we can just get some more doctors. If we haven't got the equipment, we can just get the equipment. If you need your doctors that you've got to work more hours, we can just pay them. And they've just been told money is no object. Just do what you need to do, which is weird, isn't it, as well? Completely unique situation. Yeah, I don't know how we'll be after this. I don't know if people will still see the NHS how they did prior to it. What's interesting is that the rest of the hospital, apart from the COVID wards, is pretty much empty. So A&E is just dead, like apart from the COVID patients. So you just think either all those patients who were coming into A&E didn't need to be there, or what actually worries me is that they did need to be there and now they feel too scared to come. And that's something else that people aren't really thinking or talking about. And I think it's probably because nobody needs any more negativity. But we're talking a lot about the COVID patients and COVID deaths. We're not thinking about the deaths that are happening as a result of COVID, but are not. The patients don't have COVID. So things like organ donation. So usually when people donate their organs, they're patients who have been on intensive care and have had a catastrophic injury, but are intubated and are stable enough to donate their organs. And then the recipient will need to go to ICU after that. So both of that is compromised. The amount of surgeons that are needed to perform the retrieval and then transfer it, all of that is compromised. The nurses who coordinate it, so specialist nurses of organ donation, are all ICU nurses in background, most of them. So they've been taken back to ICU to work as nurses. So they've basically pressed pause on organ donation. That's a huge knock-on effect. Like, people are going to die as a result of that. There are surgeries that have been cancelled or postponed. So at the moment, we're still doing cancer surgeries. So if someone needs surgery as a result of cancer and their 2-week wait pathway, they are still getting the surgery. But there is the potential that it could come to the point that we don't and we can't do that. So it's all those things as well. And we're seeing people, so we've got some patients who are coming through to intensive care, and maybe they wouldn't be there if they'd have come to hospital earlier, but they were at home thinking they were poorly because of COVID or trying to avoid hospitals. And that's really difficult, and no one's really talking about that.
Yeah, do you know what? I didn't even
How
think about that.
important is the testing element now? How crucial is that? Because you're saying people are staying at home, they think they might have it. If testing is widely available, would that make a big difference? I see like Germany, they seem to have like some sort of like skill to keep, like, their death rate is so much lower than most of Europe, even though there's quite a lot of infections. I don't know why that is.
Well, it's because they've tested more people. So the way that Germany have done it, I think they've done it well. They've tested loads and loads of people. The way that they've used the tests is that if you test positive, they've used it to contact trace. So they've then said you need to contact the people who you've been in contact with and tell them to isolate. Almost how we do it with like sexually transmitted diseases. So if you're found to have a sexually transmitted disease, you are asked then to contact your sexual partners and tell them. That's contact tracing. But in terms of COVID, it's whoever you've coughed on, basically. And the reason their death rates look so good is that they've tested more people. So the people who we're testing at the moment are those who are admitted to hospital. If you rocked up to A&E and you had a bit of a cough, your oxygen levels were okay, and they were going to discharge you home, they would not test you. And that's because it wouldn't change management at all. If you're not being admitted to hospital, if you're being discharged home, effectively we're going to tell you to isolate, and there would be of no benefit to anybody involved to test you when resources are so limited. However, if you are coming into hospital, if you're having to be admitted because of your oxygen requirements, then we need to test you, because we need to know whether you need to be on a COVID ward and stay there, or whether you can go to a different part of the hospital, and whether you need the COVID specific treatment or not. The swab test that we've got at the moment is not very good. Basically, if it tests positive, then you will have COVID. If it tests negative, there's a 30% chance that you still have COVID, and that in medical terms is huge. 30%. It's almost a useless test. In no other world would that test pass as a screening. It's not good enough to be a screening test, basically. So we couldn't, if I started to get symptoms and I went to get swabbed and it was negative, but I had symptoms, I wouldn't be comfortable to go to work. I'd say I'm probably in that 30%. And that we've had patients on our intensive care unit who have looked like a COVID patient. We've had to intubate them. Their chest x-ray looks like COVID, but their test is negative. And we've said, no, screw that. They're COVID. They need treating for COVID. And then we've sent a deeper sample and it's come back positive. So I think that's why we've held off using the test so much. What we're waiting for is the antibody test, which is a blood test that can test whether your immune system has already been exposed and has already won against the virus. And that will be far more useful for staff members who, if they were to have the test and say, yes, you've already been exposed, we're assuming that we will have developed immunity to it and that we can then go back to work. That's all. Again, that's an assumption though, because we still don't really have the data to show that once you've had it, you can't get it again. We're just kind of using previous models and previous science to assume that. So that's why Germany look like they're winning, basically.
All right, okay.
Because we've got lots of people who would test positive but are at home well, whereas Germany would have tested those. So our pool of patients that our death percentages being taken from are sick, as opposed to the general population, which would then make the very poorly population a tiny amount of that. If it makes sense.
Yeah, it makes a lot of sense. And do you know what? I guess, I don't know if Julian feels the same, but I don't feel like that's ever been expressed publicly, properly. I think the public it would ease a lot of fear to hear that, to say these cases that are documented as the worst cases, the worst cases. I think that would make a big difference. Like, it would put a lot of perspective on the headlines that people see. Personally, I'm not saying it's easy to say a sweeping statement. I think it would ease a lot of concern to say we've had this many infections, but these are the ones that have been tested because of, they're classed as kind of severe.
Yeah, absolutely. Yeah, and that's kind of, this is why I'm trying so hard to do this, to talk to people like you guys. And I kind of see it as the public are getting information, but because there is so much information coming out with COVID, they can only give out so much information, because otherwise it'd be information overload, nobody would understand. And then in the hospitals, we are very much getting information overload, and it's very stressful trying to decide what you do and don't listen to. But what I'm trying to do is process that information and then put it into more understandable terms for everybody else. And I've done a few videos on my Instagram about that, just trying to explain this curve that everyone's talking about and where we are on that and what people can do to understand what's going on a bit better. And there's no reason why I can't do that. What I can't do is sit down and tell you specifics about patients that I've got in my hospital. But what I can do is tell you everything else. And it's not a secret. It's certainly not a secret to anybody. It's just too much information. And someone would have to sit down and figure it out. And nobody has time to do that, I guess.
Yeah.
So thank you for letting me talk about it.
No, thank you for coming on. Like, amazing to hear what's happening and to get an insider's view from it. I think it'll benefit a lot of our listeners. I've definitely enjoyed it.
I've learned an absolute ton. Can we ask you our lockdown questions? We might have to adapt them though, because you're not actually locked down.
Yeah, okay.
I
am on my days off.
All right, well, this counts then. We'll just go with it
days
anyway.
off, yeah.
So the first question is, if you could be locked in isolation with two people, who would it be and why? They can be dead or alive.
Okay, so I sort of cheated and thought about this one. This is the only one I thought about, I think. But I listened to you ask Neil the question and was like, oh my God, who would I say? And then I thought, I have to say my fiance, don't I, as one, but we'll discount that.
played it safe. A lot of people have played it safe.
Yeah, but we'll take him out of the mix. Like, obviously it would be him because I would miss him horribly. But my two people, I would probably say Russell Brand,
Nice.
because he's hilarious, and also he's well into his like meditation and everything now, isn't he?
Mm-hmm.
So he could teach me a lot from that point of view. And then the other person would be probably Catherine Mannix, who is she's a palliative care doctor, and she's written a book called With the End in Mind. She's basically a guru of palliative care, which is what I want to do. So it would just make it very productive. I could learn a lot from her, and I reckon she'd be really good at helping people to sort of cope with this as well, so she could keep me chilled. So I reckon I'd be sweet with those two. I hope at least one of them can cook though, because my chap does all the cooking. So
take that. If you could recommend one key book for people to read during this isolation time, what is it?
What would it be? My favourite book of all time is called A Million Little Pieces. It's by James Frey, and I still to this day haven't figured out whether it's fiction or non-fiction, because it says it's non-fiction, but it's about James. He writes about himself. He's a recovering drug addict, and basically wakes up in an absolute mess and then goes to rehab. And it's such a brilliant description of everything that they feel. And I've never been in that situation, so I can't say whether it's accurate or not, but I learned a lot from that book. So, and I think in this time it would be good to read something that's not informative. So I've got loads of books that I've wanted to read. I've got The Chimp Paradox, I've got Thinking Fast, Thinking Slow, I've got The Emotional Intelligence. A couple of those are from listening to your podcast, and people have recommended them. But I just can't, when my mind's so active at work all the time, I can't get my teeth into them. I find I'm sitting down and thinking, oh, I feel like I'm working. So I've ordered another one of James Frey's books. Actually, it's come today, so I'm gonna try and read that, I think.
Nice.
So first thing you will do when this is all over?
I'll go to the gym, hands down. I miss it so much. I think everyone's in the same boat. We've got quite a good home gym in our garage as well, but it's just something about going there, isn't it? And I've never been a chatty person at the gym either. I've always been headphones on, get on with it, but I reckon I will be. I'm talking to everyone.
Chatting to everyone after this, yeah. Last question, we'll modify this one a little bit. What's this time made you grateful for?
So many things. My skill set, I guess, because I feel very lucky. What I'm most grateful for is that this time last year I hadn't done any intensive care, apart from my little bit when I was an F1, and I was in A&E. So if this had happened a year earlier, I would be working in A&E right now, and I would be having to stay in A&E and work in A&E throughout this entire pandemic. And I hated working in A&E, and I couldn't think of anything worse. So I'm so thankful that it was just a year later, and that I can be in the intensive care unit and do a job that I love. I'm really thankful that it's worked out that way.
Oh, well, that's a wrap. Awesome. It's been awesome to have you on, Steph. If people want to find your page on Insta, to get some more information about what's going on, you talked about the bell curve, getting those descriptions, where can they go at to find you?
So it's Dr. Steph _ Scrubs versus Shreds. Please don't laugh.
We'll bang that in the description below as well.
Yeah, and thank you so much for having me on. As I've said before, you guys are my favourite podcast, and I recommend you to everybody, and to come on and talk to you is an absolute honour, so thank you very much.
No, we salute you as well. Thank you. It's an honour for you to be doing what you're doing, so hats off to you during this time.
Thank
and
you.
Stay safe
Thanks
as well.
very much.
Thank you.
Thanks. I'll see you soon.
Bye.
Bye.